This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. This is Andy Southerland from the University of Virginia. Today, I am excited to be speaking with friend and colleague Scott Friedenberg, Vice Chair of Clinical Practice in the Department of Neurology at Geisinger. For this week's Neurology podcast, we're going to be discussing an article recently published in the journal Neurology Clinical Practice titled Empowering Healthcare Providers, a Collaborative Approach to Enhance Financial Performance and Productivity in Clinical Practice. In this paper, Scott and his colleagues sought to address a major challenge for us neurologists out in modern clinical practice, the challenge of balancing financial productivity with optimal patient care and our own professional satisfaction. To address this challenge, they developed a model of provider-administrative partnership along with bidirectional communication to identify and address gaps between practice patterns and preferences as it relates to work RVU generation. So with that prelude, Scott, thanks so much for joining us.
Yeah, absolutely. Thanks for having me, Andy.
As everyone out there knows, we're in a shifting financial landscape of healthcare, and certainly that's true in neurology as well. And whether we're in an academic department or out in a community practice, inpatient, outpatient, it really doesn't seem to discriminate. We're all facing increased pressures within our institutions, our practices, our own individual habits about our productivity and productivity targets. This can affect our day-to-day and certainly our mental well-being as well, in addition to patient care. So you noted this in your paper, this reality that can be disheartening for neurologists out there, but it's also one that creates an opportunity for us to sort of optimize these practices. And neurologists in general, I think, are probably not known for our extensive financial background. So I'm just curious, what motivated you and your team to take this head on? And if you could just give a little bit of a background just to bring our listeners up to the challenge you faced.
Really germinated during the time of COVID. Our health system essentially shut down, and I was offered or challenged, I suppose, with get our team on telemedicine and figure out how to make us profitable. Found out very quickly that there was a big gap between what our providers thought was great care and great service and what our administrators were fighting with during this. And we sort of put together a little brainstorming session and realized one of the places where the product producer, if that's the right word, the physician is delivering the care, but they don't really have insight into what goes into paying for that care. So as an example, we came up with, if you were to go to a car dealership and ask the car salesman, what does the car cost and what's it going to include? They would have encyclopedic knowledge. If you were to ask a physician, what's the cost of your care? What's it include? They would say, I'm not sure. So we recognized there was a pretty big gap. And the approach had always been in our practice in the past to just have a yearly meeting where we would talk to the providers about where they were at. It wasn't a good exchange of information. And so we took a step back and really looked at our practice as a whole with two basic parameters. One was, what do the providers feel like they need to be successful and happy? And second, what were the financial guidelines we needed to hit to make the practice productive? And as we started looking at that, we realized the major issue really was communication. The providers clearly wanted to deliver care, and they had no problems with figuring out how to make it financially viable. The administrators clearly wanted to make the care financially viable, but they wanted to deliver good care. They just had two different lenses. And so we put together this, as you mentioned, a bidirectional communication process to start to explore it. And the short end of it was we started meeting with really our least productive producers and found out that it was a combination of three things. Number one, it was they didn't understand billing very well, especially with the change from billing by time to billing by medical complexity. They didn't have very good control of their template, and there were just an enormous number of systemic issues that made it so that their practice weren't as profitable as it could be. So in the past, you'd have meetings with providers and you'd be like, hey, you're not at the benchmark you want. How are you going to fix it? And it was like asking somebody who had no knowledge how to fix something. So we started to put together a teamwork approach where we educated the providers on how to look at their templates and how to organize things and ask them for advice on how to make improvements. And then we, as the administrative team, became active listeners and took the mindset of providers know how to deliver good care. How do we help them do it in a way so that it's financially viable rather than in the past where the lessons seemed to be, work harder, see more patients. And it turned out it didn't need to be that way. And in most cases, by improving their billing, by improving their templates, and by improving the system itself, we brought a lot of our providers up to a good mark without them having to do major changes.
That is a laudable goal and something that we all, I think, would love to be able to do, if not, are already doing in some part within our own departments or practices. Of course, when you make change is hard for all of us. And when you're talking about change as it relates to both how we do our job, sort of our sense of professional well-being and how we take care of patients, and then you mix in financial aspects. And in my experience, folks don't like to be told they're low producers, particularly when they feel like they're going 100 miles an hour and they're doing a great job taking care of patients. So I'm curious, from a cultural standpoint, making this shift, how do you bring your colleagues along? What were some of the obstacles to doing this? And how do you think you guys were successful that others could learn from?
Again, we found out that neither the administrative team or the providers had different goals. They just were seen differently. So what we did is we started off by literally throwing away the concept of hit your benchmark. And instead of talking about hitting a mark, we talked to the providers about what do you want from your practice? What makes your practice thrive? What do you like to see? What are some of the barriers you have? What are you noticing? And it turned out the providers had pretty sharp insight. They just didn't know how to monetize it. And so through that listening to them, we came back to them and we created what we called an O to E model, or an observed to expected model. And we said to them, here's your template. Here's where we think you could be if you build this way and saw this many patients. And the surprising thing was when we showed it to them and said, hey, is this what you're doing? A lot of times they said, no, what you think I'm doing is not actually what I'm doing day to day. And so there was a discrepancy between their workload and what we expected it to be. So we had to fix that. The second round of iterations was saying, okay, this is where you are. How could we help you move up? Maybe 10%, maybe 15%. Could you add on a patient? Could you do a shared clinic? And one of our instances was very interesting. One of the providers had actually been categorized as an internal medicine doctor, and we never knew it. Literally for 2 years, he was getting downcoded on the back end, and we fixed that, and it solved his problem. And in another instance, we had 2 providers that were in clinics that were physically not large enough to handle the volume they felt they could manage. So we literally moved them to another clinic and solved that problem. So there were many times where it just took an open conversation to say, hey, we're not looking to make you work harder or get more out of you. We're looking to explore the system.
I think that something you said there is so important, and I really love it. And at least one of the many takeaways I'm going to myself use from this is sort of getting away from that idea of everybody's got to hit some target or some benchmark, because that makes folks feel like they're cog in a factory, and that's not why we went into medicine. And so I really love frame shifting that to, what do you want out of your practice? What do you enjoy doing most? How do you feel like you deliver best patient care? And let's sort of close the gap on that and monetizing your value. That's really insightful, Scott. Were you successful? I mean, I think folks go back and look at the paper. You actually provide data that this did work, right? It worked there for you guys at Geisinger?
It did. Again, going back to when COVID came to us, it was surprising that the department rallied around COVID. When we said to them, Geisinger put out this dictum, we want everybody to be at 115% for a set amount of time. And that turned out to really be our providers seeing 3 extra new patients a week. So we took that mindset of it can be done. How do we get it done? And we just started looking at individual practices, and some people did great. Some people really identified easy fixes, either with their behavior or we fixed it with their templates. Other providers, to be perfectly honest, weren't ready to make changes. We heard comments like, I was hired to be a physician, not to be a biller. And we really didn't challenge this. To be honest, when we sat down with the provider, we said to them, you're being evaluated by your productivity. We want to help you, but it's really your choice. And I think that openness to say, hey, let's collaborate was a much better message than, as you mentioned, work harder, see more patients. So I think that was a big part of what helped us be successful. And again, not everybody was. What we saw kind of across the board was providers that were on the higher end of producing really didn't make much change. And we attribute that to the fact that Geisinger had gotten rid of its incentive-based pay a couple years ago. So there was no reason to work harder. There were a couple providers that were really in a no-win situation. Our epilepsy team, for instance, because of COVID, had the epilepsy monitoring unit. So, they didn't have an opportunity. But on the back end, one of the things we saw was our inpatient service, as an example, really only generated about 20 RVUs per day compared to an outpatient provider that was generating maybe 30. So they actually came up with an idea of, hey, why don't we see a few clinic patients while we're on hospital service? So providers actually rose to the occasion and came up with solutions that improved access, that improved patient care. We tried to plug in patients they wanted to see. So it fit their desire to see good patients, and it fit the system's desire to have better access and better productivity.
That is important, and it sounds like you really strove to meet people where they are rather than forcing them into something that they were going to do begrudgingly and by virtue of that not be successful.
I think this is probably one of the key things that we came to recognize through this process. We met with providers at a minimum once every 3 months. And we sent them information ahead of time and we gave them time to look at the information and be with us. I think one of the key features when it comes to working in a system is if you don't allot time and importance to something, people aren't going to change their habits. By us spending time with them and giving them time and saying, hey, this is important, the reality was it was probably the equivalent of about an hour a month that we gave them to learn to share. And for a provider to increase their productivity from 5 to 25%, that's a pretty good return on investment. So if somebody said, is it worth it? Absolutely.
Scott, as folks listening to this are probably thinking, well, kudos to you. I'm glad that worked for you guys, but this could never work in my own institution for X, Y, and Z reasons. Mm-hmm. Do you believe this model that you all developed is something that could be widely generalizable? Obviously, there's generalizability to academic practices and so forth, to community practices. But what would be your main message to neurologists or administrators, perhaps, who are motivated to use some of the lessons that you all learned from your experience?
I think one of the most important things is create time to do this. A lot of our time before we did this, our practice process, the way that we approached billing was kind of like going to the principal's office. You brought yourself up to your chairman and the administrator. They showed you your numbers, you defended yourself, and then you went back to work feeling bad for the next week because you didn't sense things were going well. And the finances aren't a metric that as a provider we really have control over or understanding. So I think the first take-home message really is change the environment, make it positive, make it non-punitive, make it something that we're all looking for a common goal. I mean, physicians recognize when your practice makes money, you have more resources to take care of patients, you have better system health, and the system recognizes that when you have better working providers, things go better. The second thing I would say it's key is you have to be on top of your data. I know people as physicians, we like clinical data, but being able to sit down with your providers and show them simple things, saying, okay, this is a revenue value unit. This is what it looks like. And what we did is we literally showed them, hey, this is what a week's worth of work looks like. This is what you're billing. And we made it very simple for the providers to understand. Then we expanded it to this is what your month should look like. And this is what your year could look like. We did the same thing as really do with patient care. You broke down the basics and you said, here's the opportunity. If we treat you with a medication, this is what might happen. If we change your RVU productivity and you bill a level 4 rather than a level 3, this is what happens. So we made it very logical, very easy to digest. And then again, we met with the providers about every 3 months. The other thing I'd say you did is we celebrated wins like crazy. If a provider went from 45% to 48%, that was great. Again, seeing an extra 3 patients every week or billing the equivalent of an extra 3 patients per week could make a huge difference. So patting them on the back and letting them know we're there for them. The other thing, again, importantly, is we didn't make it about the money. We made it about provider satisfaction, and we made a decision as an administrative team that our job was to make them profitable rather than to make them figure out the medical billing system.
I really do love that too. It's because this is as much about, as we said earlier, about cultural change and acceptance as it is about financial and billing practices and so forth. But if not more about that, and it's about people, and you sound like really leaned into that, Scott, and and that's exciting to hear. And obviously there are aspects if you're in academic practice, and it's important to demonstrate why this then helps float all boats as it relates to more autonomy for other pursuits and so forth. So, Scott, we could continue to dig into this, and I think people are going to look to this paper as a reference text, if nothing else, and possibly you might get some phone calls to do a traveling consultant show, Scott. So keep your calendar open. And the last thing I'll say, embedded within the subtext of your paper, is the importance of introducing more financial competency into training for our residents and our fellows who are going out into practice as well, because I think that's so critical to being able to at least understand some of the foundations of this, the way that we understand it in our clinical practice. So, Scott, any final thoughts before we wrap this up here?
A couple things to touch on. One, I think the comment on educating our trainees is key. We really have moved into an age where health system science is happening. You can't, in my mind, show up at a practice and think you're just going to do work and get paid and that's it. The AAN's goal, and certainly our goals when we bring on providers, is to help them be leaders however they want to lead. You can't lead without knowledge and without effort. But importantly, you have to have time to cultivate that knowledge and you have to have a support system. So that's one of the things we aspire to deliver. The second thing is you realize that when your financial health of your practice is good, it allows your administrators and your teams to take their eye off of it and focus on other things. If you're trying to bail water out of the boat, you can't figure out how to steer the boat in the right direction. So I think there's downstream benefits to being on top of this. And if you're willing to put in a little bit of time, and in our case, our administrators were more than willing to go the extra mile. So it wasn't like the providers were by themselves. It was a team. And being on top of your data, having an analytical, and if you look at the paper there, we literally took a snapshot of their week and their productivity and went through it with them and partnered with them and let them know we understood them and we wanted them to understand us.
Scott, I think that's a great few messages for us to end on. And seek out the paper published in Neurology Clinical Practice, Empowering Healthcare Providers, a collaborative approach to enhance financial performance and productivity in clinical practice. Really look forward to this podcast getting out there. And Scott, congratulations on the work you're doing. I suspect you'll continue to be doing this analysis, so perhaps we'll hear some more longitudinal experience as it comes down the line. So Scott, thanks so much for taking this on and for joining us for today's Neurology podcast.
Absolutely. Thanks for inviting me.
If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.